Good evening, everyone. I welcome you all back to the CCI webinar series on lung transplantation. This will be the fourth part of the series, and we will be discussing about infections in the lung transplant period. So, at the outset, I would like to thank Chess Club of India and the organizers of this academic feast. A special thanks to our beloved founder, Dr. N.H. Krishna sir, Dr. Narayana Pradeep sir, our national president, Dr. Ashish Dubey sir, and our own Dr. Anil Maske sir, Dr. Vijay Kumar Chenam Chetty sir, without whose support this won't have been possible. Our course coordinators, Dr. Kapil Iyer sir and Dr. Apar Jindal sir. Today we have a star-studded panel who will be discussing about infections in lung transplant in details. We have first panelist, we have Dr. Sukhram Bishnoi sir, who is a senior consultant thoracic and lung transplant surgeon hailing from Medanta Medicity Hospital. He has special interest in VATS and robotic assisted thoracic surgeries. He'll be giving insights about surgical role in infectious complications in lung transplantation. Next, we have Dr. Unmil Shah sir, who is also my mentor, and we fondly call him as an encyclopedia of lung transplantation. He is a senior consultant transplant pulmonologist from HN Reliance Hospital, Mumbai. I welcome you, sir. Next, we have Dr. Pavan Yadav sir. Sir is a head of transplant pulmonology and interventional pulmonology at KIMS Hospital, Bengaluru. He has been in the field of lung transplantation for almost a decade now. I welcome you, sir. Next, we have Dr. Pankti Sheth. She is a young and dynamic transplant pulmonologist who has completed her clinical training in transplant from Toronto General Hospital, and now she is working as a transplant pulmonologist at Yashoda Hospital, Somajiguda branch, Hyderabad. I welcome you, ma'am. And next, last but not the least, we have Dr. Komal Jasani Shah, who is today available not just in the capacity of pulmonologist but also as an infectious disease specialist. This is a rare combination to have. She is a DNB pulmonology gold medalist from Jaslok Hospital. She has completed her clinical fellowship in infectious diseases from prestigious CMC Vellore and John Hopkins Hospital. She is presently working as an associate professor at Vasantrao Pawar Medical College, Nasik, and she is also an infectious disease consultant at Medicover and Namco Hospital, Nasik. I welcome you, ma'am. So, moving ahead. So today we'll be discussing lung transplant with initial two talks. In the first talk, I'll be speaking about post-transplant infectious complications and how to mitigate them. And in the next talk, Dr. Pankti Sheth will help us guide us with infection risk stratification and how to reduce this infection in the post-transplant period. After this, there will be a detailed panel discussion about infections in lung transplantation. Without much ado, I'll start with my presentation for today. Before I begin my talk, I'm Dr. Rahul Kendre. I'm a transplant pulmonologist from Dr. D.Y. Patel Hospital, Pune. So in this topic, I'll be discussing about prevention, diagnosis and management of infections in the post-transplant period in order to increase survival in the long term. So if we compare with any solid organ transplants, lung transplant carries the maximum burden of infections, may it be CMV, bacterial, fungal. So the reason is probably the direct exposure to the environment and the affected mucociliary clearance in the post-transplant period. So the infection usually occurs when there is an imbalance in the innate state of immunosuppression and epidemiological exposures. So innate state of immunosuppression does not just mean immunosuppression medications, but also the underlying metabolic conditions like diabetes, obesity, alcoholism. Sometimes these patients are post anti-rejection therapy. Sometimes these patients are have an underlying autoimmune disease. These conditions make them more prone for getting a infection. As for any transplant, we do induction immunosuppression for during the transplantation. And if the induction agent is antithymocyte globulin, we tend to have CMV infections more. That's the reason we nowadays prefer using anti-CD25 or IL-2 receptor antibody, that is basiliximab, which has a lesser risk of infections. Epidemiological exposures like viruses, fungi, bacteria, nosocomial bacterial infections, various parasites can lead to infections in the post-transplant. Usual source in the early transplant period are donor organ itself, or sometimes donor blood. Recipient can be harboring any multi-drug resistant organisms. Sometimes it is a nosocomial infection, and rarely a community acquired infection in the early part. In the later part, they usually carry community acquired viruses, opportunistic infections, fungi, and rarely parasitic infections. Moving ahead with donor derived infections, though they are rare, less than seen in only 1% of cases because of the thorough evaluation we do prior to transplant. But whenever they are there, they can be very high, they can lead to very high morbidity and mortality. For the same, we evaluate these patients with their bowel samples with their viral markers like hepatitis B, hepatitis C, HIV. In historical times, we used to call these presence of hepatitis B, C as a contraindication for lung transplant. But nowadays, with a good competence, we can consider these patients also. These patients, to reduce the donor-derived infections, we need to monitor the donor cultures and treat accordingly in the immediate post-transplant period. So burden of infection is so much in lung transplant that the most common cause of death in the first year of transplant is the infection. And it also increases risk of chronic rejections in the post 1 year. So to reduce this burden, we need to screen donor as well as recipients for serologies for CMV, EBV, toxoplasma. We evaluate donors with their bowel for bacterial infections, tuberculosis. In case of recipients, we check their colonization with sputum, nasal swabs. In case of viral markers, hepatitis B, C, HIV, along with COVID, which should be done within 72 hours of the transplantation, which is still mandatory for all the transplants. Usually, in the post-transplantation period, the infections follow a timeline wherein the first 1 month, usually we see more of nosocomial bacterial infections, commonly Pseudomonas, Acinetobacter, MRSA. Sometimes it could be Candida. In next 1 to 6 month period, we commonly see opportunistic infections like CMV, Pneumocystis, Aspergillus, and in the later part, when the patient starts going into the community, they can get community acquired infections, viral infections. So this is a detailed timeline graph chart. I'm not going to go in details of this. About the bacterial infections, they account for almost 50% of the infectious complications in the post-transplant period. And usually they peak in the initial 3 weeks of the transplantation. The common culprits are Pseudomonas, MRSA, and other Enterobacteriaceae. So incidence of hospital acquired or a ventilator acquired associated pneumonias is almost 7.5% in the initial 1 month, and they increase the ICU and hospital stay of these patients and prolong the recovery. So how to treat these difficult to or MDR Pseudomonas? Because we don't see any sensitive Pseudomonas strains nowadays in hospitals. Most of the time we have to consider a BL-BLI combination. Nowadays, we also have a salvage therapy with cefodaracol. And as an adjunct, in most of the patients, we consider inhaled or nebulized colistin. Staphylococcus aureus, commonly seen, is a methicillin-resistant variant, wherein we considered linezolid, ticoplanin, and in some cases where they are intolerant, we can consider levonorefloxacin. And MRSA is known to cause a necrotizing pneumonia and surgical site infections in post-transplant periods. In order to manage other gram-negative bacteria which are carbapenems resistant, we have to consider combination of BL-BLI with aztreonam, especially in cases of NDM strains. Nowadays, we are also getting meropenem sulbactam or meropenem verobactam combinations. In cases of organisms like Stenotrophomonas, we have to consider atypical coverage with minocycline, levoflox, and Bactrim. In case of Acinetobacter, in MDR cases, we usually consider a double or a triple therapy with polymyxin B, sulbactam, and minocycline. And cefotericol is still considered as a salvage therapy. So this cefotericol is nothing but a newer siderophore cephalosporin, which binds to free iron and enters the bacterial cell with an ion transport system. It should be used. Its use should be restricted only for the difficult to treat Pseudomonas and Acinetobacter cases only. Burkholderia cepacia, which was historically considered as a contraindication, especially in cases of cystic fibrosis, can be controlled in the pre-transplant period usually with meropenem and Bactrim, and still these patients can be considered for transplantation. Nocardia infection, one of the important opportunistic infections in the post-transplant period, can affect lungs, CNS, and skin. Usually it needs treatment up to 6 months to 12 months depending on the site of involvement. It is treated with high dose of Bactrim and meropenem. C. diff is a common occurrence in post-lung transplantation of almost up to 22 to 23% of cases, and it usually peaks in the initial 1 month of the transplantation, usually because of the augmented immunosuppression and use of broad-spectrum antibiotics. The usual treatment is with metronidazole or vancomycin, either locally, or we also considered vancomycin enema in some cases. Going ahead with viral infections, the most important cytomegalovirus, which gets activated because of the usage of anti-thymocyte globulin for induction or with use of anti-TNF alpha agents. After activation, it can directly affect lungs, bone marrow, GI tract, sometimes liver, and indirectly it can start an inflammatory cascade wherein it can increase risk of rejections in the future. So it has been seen those patients who have got 3 or more CMV infections in the post-transplant period have a very short clade-free survival. That is, they usually tend to have an early chronic rejection. So understanding viral bleeps is when there is a low-level viremia without any symptoms, it should be monitored closely because sometimes it could be a marker of subsequent full-blown infection. So it should never be ignored in case of post-transplant patients. We have got a consensus guidelines published in January 25. We'll be discussing it in thorough. So CMV infections is presence of CMV viremia without any symptoms or organ involvement. But a CMV disease is when the patients are symptomatic and they have an organ dysfunction. And refractory CMV, we call it when even after therapy for 2 weeks, the viral load is persistent or it is increasing. For CMV diagnostics, the gold standard is quantitative PCR, and in case of active disease, it should be repeated every weekly. Usually we screen them with plasma, but when we are suspecting an organ involvement like pneumonitis, we can consider sending a BAL for CMV quantitative PCR. In rare cases such as CMV colitis, we might have to consider biopsies to confirm the diagnosis. CMV risk can be stratified based on the CMV serology done in donor as well as recipients. Those who are seronegative, those recipients who are seronegative with a seropositive donor are considered as a high risk for CMV infections in the future. Those recipients who are seropositive are intermediate risk, and those recipients as well as donor are low risk. Those are seronegative are considered as a low risk for CMV infections. So accordingly, depending on the stratification, high risk patients will be given a prophylaxis with oral valganciclovir cumulative 900 mg daily up to 12 months, year or more, even more than 12 months. And in cases of intermediate risk, we considered them for prophylaxis up to 6 to 12 months. In low risk patients, we can replace valganciclovir with acyclovir in order to cover herpes and varicella zoster. But in our experience, many of our patients doesn't tolerate valganciclovir at a dose of 900. So many times our patients still do good with even with 450 mg once daily. So for the treatment of CMV, the mild to moderate disease needs just a oral valganciclovir, twice the dose of prophylaxis, that is 900 mg 12 hourly. And in severe cases, we have to consider IV ganciclovir at the dose of 5 mg per kg 12 hourly. This is especially we need to keep a watch on the bone marrow as well as nephrotoxicity, and dosage has to be adjusted in case of according to the creatine clearance for the ganciclovir. Letermovir is a new option, and it's a CMV terminase complex inhibitor. It has lesser myelosuppression, it has lesser nephrotoxicity, and it doesn't have cross resistance with ganciclovir. We are hoping to have it soon in India also. Recently, I think Zydus has got a approval. So about refractory and resistant CMV infections, which commonly occurs due to genetic mutations in UL97 and UL54 genes. UL97 gene is important for viral encapsulation. Maribavir is an agent which inhibits UL97 kinase inhibitor. So Maribavir is used in cases of resistant or refractory CMV infections, and I think quite a few times it has been used and it has shown good results. But we need to keep in mind that it should not be co-administered with ganciclovir. Maribavir has to be used alone. Other agents are like foscarnet, pseudofovir are rarely used because of their nephrotoxicity. CMV immunoglobulins can be considered when there is a severe hypogammaglobulinemia, when there is a life-threatening involvement by CMV, and these should be used as an adjunct to antivirals and should not be used as an individual therapy. Cell-mediated immunity assays such as talking tenoviruses (TTV), so which can give us an idea about the patient's level of immunity, and accordingly the therapy can be individualized. Immunosuppressants can be individualized, and we can avoid unnecessary infections because of augmented immunosuppression. But it will be for the future. It is still under research. In many cases with CMV or even EBV, we have to reduce or switch maintenance immunosuppression from mycophenolate to mTOR inhibitors. mTOR inhibitors have an added advantage of having antiviral properties. Epstein-Barr virus, though it's a rare compared to CMV, but can lead to post-transplant lymphoproliferative disorders. And there is no there is no direct therapy against VV, but we have to optimize the immunosuppression. And in cases of PTLD, we might have to consider rituximab. In the later part of the transplant period, we usually get community-acquired respiratory viral infections with influenza, RSV, parainfluenza, and these should be treated usually with oseltamivir as early as possible. And because they tend to not just aggravate risk of acute as well as chronic rejections, these can be prevented with the use of annual vaccination for influenza. In case of severe RSV infection, we usually considered inhaled ribavirin. COVID-19 in post-lung transplantation, though it has become rare, but can be a very life-threatening infection. Remdesivir still remains the mainstay of treatment, as Paxlovid has significant interactions with calcineurin inhibitors, that is tacrolimus. Moving ahead with the fungal infections, though fungal infections are seen in only 8 to 10% of the patients in the first year of transplant, but they contribute to 35% of the mortality associated with infectious pneumonias in the first year of transplant. Most commonly, the fungi involved is Aspergillus, the mold, and sometimes it is Candida. So these can be diagnosed using bile cultures or with biopsies. Sometimes when we couldn't get a diagnosis on bile culture and biopsy is not possible, we can consider doing a bile galactomannan, which is more sensitive than a serum galactomannan, which can be false positive in many instances. Beta D glucan is a pan-fungal marker and is not considered specific for Aspergillus. In the literature, invasive fungal infections are seen commonly in lung transplants, and which are more almost double compared to other solid organ transplants. So antifungal prophylaxis is of paramount importance in such patients, lung transplant patients, usually with voriconazole and sometimes with posaconazole, as it also has added advantage of activity against mucormycosis. We also start these patients with inhaled amphotericin B. For the treatment of invasive aspergillosis, voriconazole is the preferred agent, but the dosage should be adjusted as per the therapeutic drug monitoring, and the target level of 1 to 5.5 microgram per ml should be achieved. Isovuconazole is an alternative which is non-inferior to voriconazole and has fewer side effects and a better pharmacokinetics, but the cost limits its use usually. Other emerging antifungals like risafungin and others are coming up in pipeline. Candida infections are usually treated with echinocandins. Pneumocystis carinii pneumonia prophylaxis should be given lifelong. As the literature mentions, those who have not received PCP prophylaxis tend to have a PCP attacks up to almost 43% compared to less than 6% who are on prophylaxis, and the risk of infection increases more after the first year of transplantation. As we are a TB endemic country, TB can be seen in literature. It mentions about 6 to 10%, but I would say in Indian setup, we see even up to 15 to 20% at some centers. That's why we need to screen these patients, donor as well as recipients. We do donor screening with BAL, CBNAT, with CT scan, and recipients with interferon gamma release assay, and in some cases when required sputum as well as BAL in recipients also. So that therapy will be because we can't consider rifampicin in these patients because of its interaction with the CYP 450. It's a strong inducer and it reduces the CNI levels so significantly that we preferably use rifabutin rather than rifampicin, and that's the reason we usually extend the therapy up to 12 months or more. Similarly, non-tuberculous mycobacteria pose a risk in the post-transplant period, especially Mycobacterium abscessus, which is very difficult to treat. It takes almost 2 to 3 years for treatment, and they usually need IV amikacin, meropenem. Parasitic infections, though rare, can be a cause of severe diarrheas in the post-transplant period, especially due to strongyloidosis, for which we usually give them ivermectin prophylaxis. Hyporammonemia syndrome is a dreaded complication due to donor-derived urea-splitting organisms like ureaplasma and Mycoplasma hominis. This usually carries very high mortality and usually presents as a elevated ammonia levels with encephalopathy and with a normal liver function in the early post-transplant period. So infection not only increases short-term risk, but also has a chronic increases risk of chronic rejections and bronchiolitis obliterans, that is chronic rejection. So vaccination is of paramount importance in pre-transplant period for pneumococcal, influenza, Tdap, hepatitis, MMR, varicella. Preferably live vaccine should not be given within a month of transplantation. Post-transplant, only inactivated vaccines can be considered. Usually we ask patients to have an annual flu vaccination in the post-transplant period. So apart from the anti-infective prophylaxis, patient also need to do lifestyle modification in the form of avoiding exposure to dust, avoiding pollution, should be very vigilant about their food intake. They should not be eating any undercooked meats. They should not be eating any raw vegetables or raw fruits. And to summarize my talk, in order to prolong survival, we need to screen these patients regularly. We need to give a appropriate anti-infective prophylaxis, and we need to keep them monitoring for infections in the post-transplant period. Thank you. And now I'll hand it over to Dr. Pankti. She'll be guiding us about the post-transplant, how could we reduce the risk in the post-transplant period. Thank you.
So I will be discussing about infectious risk optimization pre-lung transplantation from MDR colonization to TB endemic realities. Now, why are we talking about this? As per the ISHLT registry, infection is actually the second most common cause of death after graft failure in lung transplant recipients. However, a lot of papers and a lot of series have suggested that infection is actually the most common cause of death in patients who have undergone lung transplantation. And what is the source of this infection? So basically, our lung transplant patients requiring immunosuppression for lifelong immunosuppression leads to lifelong susceptibility to infection. Sources being direct exposure, continuous exposure to external environments, altered surgical anatomy, that is the surgical changes that have been done, and the denervation leads to impaired mucociliary clearance. The important thing that we have to discuss is prior colonization of difficult to treat organisms prior to transplantation, right? And as per the Swiss transplant cohort data, now this cohort actually has analyzed patients with solid organ transplant recipients, and they have said that patients who have undergone lung transplantation are actually at the highest risk of infections as compared to all other patients with solid organ transplantations, right? And 63% patients of all infections in lung transplant recipients were bacterial in origin, and the highest risk of infection with a bacteria or any kind of infection in the is in the first 30 days post transplantation. The commonest sites of infection being lungs, that is pneumonia, and sources of infection could either be donor derived or it could be recipient colonization, especially in patients with cystic fibrosis and non-cystic fibrosis bronchiectasis. Having said that, any patient with structural lung disease such as interstitial lung disease, we've encountered them having colonized with MDR pathogens. And other source of infection could be nosocomial, such as catheters and ventilators. Now, what are the multi-drug resistant threats that we face in patients who are planned for transplantation? The most common is being MDR, Pseudomonas aeruginosa, and Burkholderia cepacia complex, which are being discussed in detail every time. And then we have MRSAs and BREs. These are actually associated with increased mortality and graft rejection, especially in the first 1 year of post-transplantation, and hence the screening and decolonization is absolutely recommended. Now, over the past decade, over the last 10 years, a lot of case series have come up with the fact that other organisms such as Stenotrophomonas, Achromobacter, Acinetobacter, there is an increased prevalence of these MDR pathogens as well. And the pre-transplant colonization or infection can lead to fatal post-transplant pneumonias in patients. And careful sensitivity testing is absolutely required for these patients. Now, Pseudomonas, our very own Pseudomonas. It is actually one of the most commonest cause of post-transplant pneumonias in the first month, and the risk of pre-transplant colonization with Pseudomonas increases the infection risk by at least 5 times post-transplantation. So in a lot of series, cystic fibrosis patients have been they've isolated MDR strains of Pseudomonas in at least 45% of the patients, but there are series which have isolated in at least 80% of the patients, which is very, very high. MDR strains mean that these bacteria are resistant to at least 3 groups of antibiotics. Also, why are we talking about this? Pseudomonas aeruginosa colonization and infection is associated with high levels of interleukin 8, and this interleukin 8 dependent neutrophilic airway inflammation is highly associated with development of CLAD and especially the BOS phenotype. It is also associated with development of donor specific antibodies, which is why we are scared of this bug, right? Having said that, colonization with Pseudomonas is not a contraindication to transplantation. Perioperative treatment typically is tailored to historical isolates initially till we actually get a new sensitivity pattern in case if the patient is infected with it. And inhaled tobramycin is associated with reduced exacerbations in patients who are colonized with Pseudomonas prior to transplantation. Role of endoscopic frontosphenoectoidectomy to reduce the risk of allograft colonization is still controversial and it is not being used in practice. Coming to Burkholderia cepacia complex, Burkholderia cepacia complex comprises of a distinct genomic species with varying virulence, and accurate identification of the species is very, very mandatory. Why? Because Burkholderia cepacia, one of the species, is highly associated with necrotizing pneumonia and sepsis and is associated with very high mortality, as high as 80 to 90% post-transplantation. Hence, it is being considered as an absolute contraindication to lung transplantation in many, many centers, and a lot of other centers consider it as a relative contraindication. Other Burkholderia species such as Burkholderia multivorans and Burkholderia gladioli is also associated with high levels of infection such as mediastinal abscess and chest wall infections, and is often considered as a relative contraindication in a lot of centers. The management requires a prolonged therapy of antibiotics, the first line of drug being cotrimoxazole. Having said that, a lot of species are now resistant to trimethoprim, sulfamethoxazole, and may be treated with ceftazidime, avibactam, or meropenem. The resistant gram positives, MRSA, are very old MRSA. Pre-transplant colonization increases the risk of post-transplant infection by at least 5 times, and it is associated with high mortality and graft rejection, especially in the initial 1 year post-transplantation. Hence, screening of the respiratory tract is very important, and decolonization with mupirocin, chlorhexidine bathing may reduce the risk of post-transplant infections. Also, perioperative vancomycin prophylaxis is a standard for colonized patients. Vancomycin-resistant enterococci, colonization is a risk factor for VRE bacteremia and mediastinitis post-transplantation, and the risk factor for VRE being prolonged hospitalizations and prior antibiotic use. This is something why we are talking about is because now a lot of transplant centers have patients who are on prolonged mechanical ventilation and ECMO, and I am assuming that all of us have encountered VRE in these patients at some point of time, and this is actually associated increased mortality in post-transplantation in the 1 year post-transplantation. The management being contact precautions and treatment with linezolid for active infections. Acinetobacter, very notorious. Most of the strains that we are encountering on our ICU are either pan-resistant. Most of the strains that we encounter are now pan-resistant. It is increasingly common in patients who are being treated in the ICU for a prolonged time on mechanical ventilation or are on ECMO, and some of these strains are sensitive only to cholesterol or tigecycline. The mortality is very high in some of the case series, as high as 90% post-transplantations, and hence active pan-resistant infection may preclude listing until the infection is controlled and the cultures are negative. Tuberculosis, in a country like ours, which is endemic to tuberculosis, lung transplant recipients face a very high risk of infection with TB post-transplantation, especially in the 1 year post-transplantation. The risk can go as high as to 73 times as compared to the general population. If not treated adequately, the mortality can be as high as 20 to 25%. Hence, it is mandatory to screen for LTBI prior to transplantation, either with the use of TB quantiferon gold or tuberculin skin test. So, in a lot of series, TB quantiferon gold has actually preferred because of its higher specificity and not affected by prior BCG vaccination in TB endemic area, especially. Tuberculin skin test, there is evidence that there is a high rate of false negative in cases, especially in cases who are highly immunosuppressed or in end-stage organ failure. And of course, chest imaging is required to rule out active disease. The treatment of LTBI, the goal is to treat prior to transplantation to prevent reactivation, and the treatment being isoniazid for 9 months, which is the standard, or the other combination therapy of rifampicin and isoniazid is an alternative. And then coming to non-tuberculous mycobacteria, the most commonly isolated non-tuberculous mycobacteria are either Mycobacterium avium complex, followed by Mycobacterium abscesses. Now, Mycobacterium abscesses, if isolated, is actually a relative contraindication to lung transplantation unless it is eradicated, because Mycobacterium abscesses poses a very high risk of post-transplantation infection if not treated adequately, and it is associated with high mortality after transplantation. So all of us have spoken about Aspergillus colonization in structural lung diseases and bronchiectasis in cystic fibrosis. And now Scedosporium and Lomentospora. These are actually the emerging fungal pathogens, particularly in patients with cystic fibrosis. And there are a lot of papers on there, lot of papers saying and proving how the mortality worsens. There is so much of how the mortality increases after transplantation if the patient has been isolated with Scedosporium or Lomentospora prior to transplantation. Now, the Scedosporium shows moderate resistance to antifungals, and the drug of choice is voriconazole if identified prior to transplantation. Lomentospora shows pan-antifungal resistance. Hence, isolation of Lomentospora prolificans is often considered as an absolute contraindication to transplantation. If Scedosporium is isolated, it requires aggressive pre-transplant treatment with voriconazole. So, to conclude, a comprehensive infectious disease evaluation does not just clear a patient for surgery, it creates a personalized roadmap for their lifelong immunosuppressed journey. I would like Dr. Rahul to take over, and thank you for your patience.
Thank you, Dr. Pankti. That was a lucid presentation. And now we will move on to our panel discussion, which we are excited about. Unfortunately, Dr. Sukhram sir had to leave because of a transplant call. So we wish him good luck and we will miss him. But we'll start with Dr. Komal. Dr. Komal, being a ID specialist and a pulmonologist, how do you differentiate colonizers from a true infection, especially in pre-lung transplant patients who are having recurrent infections or recurrent exacerbations?
Good evening, everyone. And I would like to first thank CCI and everyone for giving me the opportunity. An excellent question, sir. Excellent presentation, first of all. And excellent question that how do we differentiate colonization from actual infection? Because these are the patients, COPD, cystic fibrosis, ILDs, who are having repeated exacerbation. And there is mucostasis, because of which there is colonization. So we must rule out. So what I would like to say here is that we do not treat one report, one microbiological report or one sputum report or ET report. It should be in combination of everything. In a way, we should first see the clinical picture. Again, this could be misleading because the patients are on immunosuppression sometimes on antibiotics. So they might not show the actual signs of infection. So we must see whether it is in correlation with everything else, like fever, cough, increase, the change of quality of sputum, color of the sputum. Then we must look at the radiological picture. Are there any new signs of infections like tree in bud appearance, new infiltrates, or anything new that is present, new shadows, consolidation? As far as the biomarkers are concerned, we can take help of galactomannan or beta-D-glucan if it is fungal infection. And procalcitonin is a very important biomarker. If it is high, we can suspect bacterial infection rather than colonization. And finally, the microbiological culture. Here, we must look at the colony count. If it is more than 10 raised to 5, it shows us that there is infection rather than the colonization. Even in the rapid PCR panels, now we are getting the threshold. So if the threshold is less than or more than 10 raised to 5, it shows the infection with the presence of genetic mutations. So it should be the combination of clinical, radiological, microbiological, and of course the biomarker. And if all four are pointing towards the infection, it can be the infection, not treating one single report.
Points very well taken, Komal. So now I move on to Dr. Pavan sir. So how do you assess your patients for these MDR pathogenic colonization versus an infection, and how does it affect your decision making for listing these patients, and does it also change your management in the post transplant?
Yeah, so Especially, we segregate dry diseases and lung and wet diseases. For example, patients with bronchiectasis and post-tubercular lung disease, where there is the lungs are wet and colonization with organisms. So we know that these organisms are not going to go away, and we need to try to understand as to what is the colonization that has happened, and then if there is any repeated infections and the patient has been admitted repeatedly with a particular infection, we try to treat them as much as clinically symptoms of active infection. And if it is just a colonization, we can part of it. We do take the swabs, the nasal swabs, the rectal swabs, the renal swabs to look for any colonization. Especially, we are worried about the gram negative GPCs and GNBs, which are MDR in nature, and those are the ones which we have to be really careful about. Apart from that, our patient is on ECMO and awaiting at lung transplantation as a little tricky situation because they can have multiple lines, multiple plastic insertions across the body, and they may be having active infections, which needs to be considered seriously. And also, if there is an active infection, which may be a little difficult to identify and treat completely before taking them for the transplant procedure. So, how does it really affect in the post-transplant period? So, it depends. For example, if you have wet lung like bronchiectasis, etc., unless the lung is completely taken out and replaced with a new pair of lungs, the infection wouldn't definitely go away. However, post-transplant, there is always a risk of these organisms being there in the airways, and which can cause infections of the transplanted lung. And apart from that, of course, the newer tools, as the previous speaker was mentioning about the PCR analysis, the newer RNA DNA assessment do tell us about the organisms which are colonizers. And I think most of the infections we can go ahead unless the patient is showing clinical signs of active infection, especially sepsis. If you have infections being identified in the bloodstream, or if you take a sample from the lungs which shows any infection, especially MDR, etc. So we just have to be careful.
Absolutely agree, sir.
And anything else? I think, yeah.
So I agree with your point, sir. So now moving ahead to next question to Dr. Unmil, sir. So many of our patients are ECMO bridge to transplants because either they are delayedly, they present us very late, or they are in exacerbation when we have to put them on a ECMO and then we go for a transplant. So in such patients, does the infection risk differ from a normal pre-transplant patient?
Yeah, so I think that's a very practical question. And in a high volume lung transplant unit, we almost have 20 to 30% of the patients who are ECMO as a bridge to lung transplant. And usually the ECMO runs are for a longer period of time because of the general shortage of the organ donations in the country. So basically, as we know, whenever we have most of the patients, those who are as the ECMO bridge are predominantly VV ECMO. There are predominantly two main cannulas. One is the jugular one, the IJV one, and other is the FEM one. And usually most of these patients would have other multiple lines also in situ. So whether it is a central line in place, they would have Foley's catheter in place, they would have arterial line in place to monitor the blood gases. So there are multiple lines. There are two main big cannulas. One is the drainage, other is the return one. And usually there is a lot of handling of these lines, cannulas. Patients also, it also depends upon what was the reason for going into a respiratory failure and landing upon ECMO. So whether it was an infective exacerbation and which has landed up the patient on a ventilator and ECMO. So usually we keep a very low threshold for infection screening or on patients, those who are ECMO as a bridge to transplant, because the very fact they are bridge to transplant, we need to maintain the candidacy for the lung transplant, and we need to make sure that we are able to effectively treat the infections. Usually we see as the ECMO days keep on increasing, there are multiple waves of infections and we have to keep treating those. We need to have a low threshold for surveillance for pan cultures, whether it is doing BLs on patients, those who are on ECMO and tracheostomized, whether it is sending multiple blood cultures from different sites, whether it is repeating urine cultures, etc. So I think usually, and with the prolonged stay in the hospital, most of the bugs are going to be multi-drug resistant organisms. So sometimes it becomes a challenge treating those infections. Again, another important point is the cannulas are for a longer period of time, and the multi-drug resistant infections tend to develop a biofilm in the cannulas. Now, it is easy to change the central line. It is easy to change the arterial line. It is easy to change the Foley's catheter. But changing the ECMO cannulas is not very commonly practiced, and that is why the biofilm sometimes tends to remain in those cannulas, and sometimes, despite treating effectively with the culture report based antibiotic, sometimes you can get repeated cultures positive, and that is also something which we have to keep it in mind.
So do you also increase the antibiotic dosages while patients are on ECMO?
Right. So that depends upon what type of antibiotics we are using. So whether they are protein bound or whether they are lipophilic. So it all depends upon that. So if they are protein bound, then you don't require the dosages to be increased. But otherwise, we need to increase the dosages.
Okay, sir. Agreed. So moving ahead, Dr. Pankti, you had during your talk, you had mentioned about the latent tuberculosis. As we are an TB endemic country, and most of our patients might be having a latent tuberculosis. And how do you approach such patients, and especially if these patients turn out with active tuberculosis during evaluation or during waiting for transplant? How do you approach such patients?
Hello, sir. So because we have to give immunosuppression to these patients post-transplantation, so we always worry about fulminant reactivations or disseminated diseases. So that's why all candidates who are planned for transplantation ideally have to be screened for latent tuberculosis infection and active disease, preferably with TB quantiferon gold. Because tuberculin skin test may give there will be a higher prevalence of energy in end-stage lung disease. If the screening for LTBI is positive, then ideally we aim to complete the prophylaxis before the transplantation. The regimen constituting, of course, as per the guidelines, isoniazid or an alternative regimen in case if you would need a shorter regimen with isoniazid and rifampicin. And patients can generally remain active on the list after initiating the prophylaxis for LTBI. By chance, if the regimen wasn't completed and the transplant is being done, then the treatment should be resumed as soon as the patient is stable enough. Preferably, rifampicin should not be given because then because of the drug interaction, the TAC levels will be reduced significantly. If these patients are diagnosed with active tuberculosis is an absolute contraindication for transplantation. So the patient has to complete full course of anti-tubercular therapy with documentation that there is microbiological cure and radiographic improvement before we reactivate them in the list. In some cases if transplantation is just an absolute salvage treatment, in salvage cases, then listing may be considered after completing the intensive phase and cultures are negative, sir.
Yes, agreed, Dr. Pankti. When you are considering such patients after an intensive phase, because we are worried about the colonization of the trachea and the proximal bronchus, which will be the same in the post-transplant period, we need to rule out that colonization of those areas also. Especially we prefer to do a PET scan in such patients if we are considering for a transplant immediately after initial therapy.
Correct.
So coming back to Dr. Komal, in the peak seasons with H1N1, COVID or some other viral infections, we see a lot of ARDS patients, and they tend to have a significant mortality. So can these patients be considered for lung transplantation, and when should we refer such patients for lung transplantation?
Yeah, again, a very good question. So these patients like post-COVID fibrotic ARDS with irreversible lung damage, they can be considered for the lung transplant, provided they should be ventilator dependent, they should be dependent on ECMO, and they should not be any major organ damage like renal and hepatic dysfunction. They can be referred after 4 to 8 weeks when the patient is on ECMO and ventilator, but without any organ damage. There should not be any active sepsis when we are considering the patient. Matlab ki PCR should be negative at the time. These are the criteria. Maybe anyone else can add on to this list if there are more criteria.
So per se, we don't have to wait for a certain amount of time. If the lung has become fibrotic, if it is maybe 4 weeks, 6 weeks, 8 weeks, depends. And if we are given a trial of on ECMO, you have waited for some time to reverse the condition, and if it is not reversing and it has gone into fibrotic stage, then I think we can consider such patients at the earliest. So moving forward, back to Pavan sir. Sir, with the availability of rapid diagnostic tests like multiplex PCRs and biomarkers, how do you use them in your practice in the peri-transplant period?
So, in our experience, I think the BioFire panel has been very, very helpful for us. And some centers say that high sensitivity and false positivity rates are quite high. But in our practice, the way we take samples, probably we take deep samples, and it has been extremely helpful. And also the turnaround time is just about 2 hours. So we get the complete panel for virus, the bacteria, and also the most helpful one is about the resistance patterns that we get, like APC and the resistance pattern, which are extremely helpful in changing the antibiotics. Because when the patient, especially post-transplant, in the immediate post-transplant period on immunosuppression, when they become sick, they can become sick very fast. So these panels are extremely helpful, and the method of collecting the samples is very important here. And apart from that, the range of the organism which the panel gives, not only there may be simultaneous infection with bacteria as well as virus. So in those situations, viral panels are very difficult to get with only the cultures, right? And also the bacterial cultures may take about 48 hours or more than that. And until then, these panels can be very helpful in picking up those infections.
Great, sir. Correct. So moving ahead, Dr. Pankti, though the donor-derived infections are rare, but if they are present, they can be devastating. So we usually have a very short span of time after we get a retrieval call or a donor call. So in that short span of time, how would you evaluate the donor?
So yeah, very important. So the donor evaluation is actually just not about the quality, that is assessing the oxygenation, whether there is pulmonary edema, but it is also about the microbiological risk that it possesses post-transplantation in the recipient, right? So a donor with purulent secretions or a positive gram stain may automatically not be declined, right? The donor bile is carefully evaluated. Obviously, the secretions, whether we see whether there is returning of secretions after the suction is being done after bronchoscopy, and also the previous tracheal culture reports in the hospital are being assessed and checked for their microbiological sensitivity. So if the recipient is on ECMO or if it is in high urgency, then the lungs may be accepted with the donor bacterial cultures guiding the antibiotic coverage in the post-op period. If we do not have any culture sensitivity in the beginning, then of course we start with broad spectrum antibiotics, and the donor sensitivity that we eventually get, the culture reports that we eventually get, will guide the antibiotic management. So yes, it is very important that we evaluate not only on the perspective of the oxygenation, but also for infections.
Exactly. So moving ahead, Unmil sir, many of our patients who are in exacerbation and waiting for transplant, when should we suspect CMV in pre-transplant period, or especially if they are on, they are being put on ECMO? When do you suspect CMV in such patients? And does it rule out having a positive CMV prior to transplant? Does it rule them out from the transplant?
So these are very practical questions. Now, most of the time when you have patients landing up in infective exacerbation and landing up on ECMO or getting intubated, definitely we have to keep a low threshold for what was the reason for the infective exacerbation. Apart from the routine screening for bacteria, fungus, we also screen for the viruses, whether they are community acquired viruses or whether there was any CMV viremia. Secondly, most of the fibrotic ILD patients or end-stage lung disease patients, they are on a combination of steroid, which has been chronically going on, plus or minus with an anti-inflammatory, whether it is Myfortic, which is, or MMF, which is going on, or whether there is Azoran or azathioprine, which has been given. Sometimes we have CTD ILD patients which have received a pulse of rituximab or a pulse of cyclophosphamide for a progressive connective tissue disorder, and which has landed up, which has eventually the patient has landed up in an infective exacerbation. So definitely keep a low threshold for looking for CMV. It's CMV also we screen for all our recipients also, whether irrespective of whether they are on ECMO or not. So that has been our standard protocol to screen for CMV. If we come across low level viremia, predominantly pre-transplant patient is awaiting organ transplant and has been on ECMO support, we usually tend to treat those low level viremias also, because we know that once the organ is available and the transplant happens, patient is going to be on a triple drug immunosuppression, where you can have a flare up of CMV viremia happening if it is not being treated. Definitely it does not become, I mean, practically if we go through, if we have sufficient time to treat, if we have picked up the CMV viremia much earlier on, patients awaiting lung transplant and on ECMO support, we are able to effectively clear the viruses before the organ is available. Even though suppose the organ is available, suppose we have started the antiviral therapy and maybe within the next 72 hours or maybe in the next 3-4 days, if the organ is available, we definitely run through the CMV viral load pre-operatively before the patient is getting shifted for transplant. But it does not become an absolute contraindication, because the low level viremia, most of the patients, predominantly those who have been chronically and overtly immunosuppressed, would definitely have some amount of low level viremia. So definitely go ahead and treat it. Yes, we need to perioperatively also effectively cover with the antiviral cover. Sometimes we also combine CMV, IgG, immunoglobulin along with the antiviral perioperatively to cover the such patients who have been evidence of low level viremia preoperatively. As far as the post transplant is concerned, as a universal prophylaxis, we use valganciclovir for all our patients, because in India predominantly we have D plus R plus. So just for a basic etiology, or for the basic audience to understand what is this terminology, D plus means that the donor is also IgG CMV positive and you have recipient also IgG CMV positive. So you have 4 categories of subset of this donor recipient combination. So either you would have D plus, D plus R minus, or you would have D minus, R minus. So the most higher risk, the highest risk is always with D plus and R minus, okay, as compared to the D plus R plus, which comes into the intermediate risk. So as a universal prophylaxis, we use valganciclovir for all our patients. Those who are not able to tolerate valganciclovir post transplant after starting immunosuppressions, then definitely we have to knock the valgan out of the protocol or out of the drug list, and we keep a surveillance of monitoring the CMV viral load every monthly or sometimes every weekly in the initial phase, to get an idea about how is the triple immunodrug suppression going on. Sometimes the low level viremia CMV also indicates whether you are overtly immunosuppressing the patient post-transplant. So definitely CMV plays a very important role. And as we know, CMV is a risk factor for acute rejections post-transplant and also for the chronic rejections, or CLAD, or what we say chronic lung allograft dysfunction. So definitely keep a low threshold for looking for CMV pre and post-transplant.
Absolutely agree, sir. So going ahead, Dr. Pankti, as we say that bacterial sepsis is the most common cause of morbidity and mortality in the immediate transplant period. So how do you manage your patients? How is your antibiotic strategy in empirically managing these patients, and also about the MDR organisms?
So in our center, we typically start with broad spectrum coverage, preferably with meropenem and teicoplanin. If the recipient had any pre-transplant colonization or any cultures positive, such as MDR, Pseudomonas, or in case Burkholderia or any other organism, then targeted therapy is actually preferred for another 14 to 21 days post-transplant also, depending on the cultures, and the new cultures are awaited. For difficult to treat organisms such as carbapenem resistant Pseudomonas or carbapenem resistant Acinetobacter, there are other evolved antimicrobials, as you've discussed in your presentation also, such as cefiderocol, which is a cephalosporin, has excellent activity against carbapenem resistant strains. And then we have ceftolozone with tazobactam also, again having excellent activity against MDR Pseudomonas. Then we have ceftazidime avibactam, which is quite effective for KPC and OXO48 producing organisms. So yes, the broad spectrum empirically till we have any cultures positive, and depending on that, then we'll have targeted therapies.
Agreed. So going ahead, Pavan sir, after the transplantation, any opacities on chest X-ray may not be infection always. So it could be rejection or an infection. And in this dilemma, how do you assess these patients for rejection versus an infection? And if you are suspecting is a coexistence of both, how do you manage such patients?
Okay. So first will be the timeline. So basically, immediately post-transplant, within a month or so, we usually suspect any acute worsening of X-ray or clinical worsening. We usually think about PGD, followed by infections and later rejections. After a month later, then we think more about the possibilities of infections and rejection. So the timeline is very important as to at what point of post-transplant period we're looking at. The second will be, of course, the clinical presentation. If the patient has fever and then BP is going low, sepsis, features, multi-organ involvement, etc. So we think more about the infection aspects here. And then the third will be the imaging, as you suggested. So if there is any local pathology, local opacity, infiltration, etc., it's probably a localized infection, more like a bacterial infection, fungal, etc. But if it is a diffuse ground glass or diffuse infiltration in both the lungs, and in such a situation, we would definitely go for a CT scan rather than an X-ray, because CT scan definitely gives much more greater information than as compared to simple chest X-ray, because it can be either a fluid or it can be an infection, it can be a rejection, so it can be a PGD. So multiple factors can happen in a post-transplant graft. So the imaging definitely helps a lot in this situation, followed by a bronchoscopy and a bronchoscopic sampling from the area of infiltrate. We take a lavage and you run for a PCR-based test, get a rapid response, and then we get look at the organisms which have been picked up. And if most of the organisms come back as negative, and if your procalcitonin is negative, and then you look for other markers like SABs, etc. And if your TAC levels have not been maintaining well, if immunosuppression levels have not been adequate, then you suspect rejection pathology. And then after, of course, if it is possible, if it is a little later in the time, we can do a biopsy also to confirm whether there is any rejection and type of rejection. Depending upon the type of pathology, histopathology that comes back, we can treat it accordingly. So, but often there can be an overlap of rejection and infection itself can predispose to rejection. And in this situation, we have to be careful. If the infection is very severe, leading to the level of sepsis, obviously we have to slow down our immunosuppression, and we may have to stop MMF or azathioprine for a few days until the infection is taken care of. Steroids usually don't stop because it may cause adrenal insufficiencies, and we may have to escalate the antibiotics there. And once the infection is adequately treated, then we can obviously come back to the rejection aspect of it, because infections can kill patients in a very short period of time, and rejection will usually give us a little bit of time to manage. So this is how probably we manage it.
Yes, sir, I agree. So it's a basically balancing act in immunosuppression versus antibiotics. So going ahead, Dr. Komal, so now we are on our patient has now post-transplant few months, and now he develops or reactivates tuberculosis and comes to you. How do you manage such patients after transplantation? Is it the same, that the treatment strategy would be same as for a normal TB patient, or will there be any change?
Of course, there will be many changes. First, if it is DSTB, we cannot use rifampicin, as you mentioned in your talk as well, because there is a lot of drug-drug interaction, and it will decrease the dose of TAC. So we have to increase the dose of tacrolimus 4 to 10 times if we want to use rifampicin. So one option is we use rifabutine in place of rifampicin. Again, this is also, there are more drug-drug interactions, but it is on the milder level. It is not available in the program, rifabutine. Patient has to purchase it by himself. Now the dose is around 5 to 10 milligrams per day. But if rifabutine is also not available, then we can replace rifampicin with fluoroquinolones here, where we need to look for the QT prolongation very specifically. However, whether we are using rifampicin or fluoroquinolones, total duration of the treatment should be 12 months at least, because we are replacing rifampicin here. Now, this is for drug-sensitive tuberculosis, but if it is drug-resistant tuberculosis, it is all the more difficult, because again, we have drug-drug interactions. BDQ has drug interactions. Plus, if we are using linezolid, there is additive myelosuppression. If we are using fluoroquinolones, there is QT prolongation. Aminoglycosides will lead to additional renal problems. So we need to be very careful. In MDR, we can give medicines as per the drug cultures DSTs, but we have to be careful. And again, the duration we need to decide as per the clinical and radiological recovery. But again, it is a longer treatment and which should be continued for 2 years.
Yes, Dr. Komal. So moving ahead, Unmil sir, so similar to TB, we also come across NTM in many of our post-transplant patients. Either they are pulmonary NTM or sometimes it is a soft tissue involvement like chest wall. So how do you treat such patients of NTM and how long should we treat?
So the first is obviously these are all post-transplant patients. So the diagnostic modalities more or less remain the same. So you need to do a chest CT scan. You need to keep a low threshold for doing a BL or the bronchial washings if there are any lung involvement, and send it for cultures. And obviously send it for NTM identification and susceptibility testing as we routinely do. Now, once in the meantime, suppose you have an empirical treatment or plan to be planned for. So you have a gene expert which is negative. Okay, and you have an AFB smear which is positive, which points towards that likely that this could be an NTM pathology. So in these scenarios where you have an AFB smear positive and gene expert negative, and there is a very high clinical suspicion that this could be NTM. So the empiric treatment for any NTM before you get a culture sensitivity will be either a macrolide along with ethambutol. You can use an aminoglycoside if the RFTs are fine, and if you can manage your renal function test along with the other immunosuppressants, and or plus minus you can use the rifamycin. So whether it is either rifampicin or rifabutin. Once we have the NTM species identified, now whether it is MAC or whether it is Mycobacterium abscessus or whether it is Mycobacterium kansasi, then accordingly, depending upon that, we will have to have a tailored regimen planned as per the culture sensitivity available. So if it is a MAC, then obviously preferably we would go for ethambutol, macrolide, whether it is azithromycin or clarithromycin, and plus minus and rifampicin. Whether if it's a non-cavitatory Mycobacterium abscessus, then definitely we would focus more on azithromycin, amikacin, and imipenem and stuff like that. So I think it all depends upon the culture sensitivity. The duration of the treatment minimum remains for 12 months. Once we have started the treatment, yes, I mean, once the culture comes negative, the general consensus, there was an international Delphi paper which was published 2 years back in ARJ, and then that is definitely, it was a Delphi consensus statement, and they definitely came out with the basic guidelines that in a post-lung transplant, at least minimum 12 months of therapy after the culture report comes negative. And that is something which is a basic guideline which is usually followed. So usually, whether it is Mycobacterium abscessus or whether it is Mycobacterium kansasi, at least keep a 12 months of treatment duration after the first culture report comes negative. Also remember, this is a post-transplant stage. So definitely consider dose reduction of immunosuppressive treatment, because unless and until you don't do that, the infection is not going to get cleared. After a particular period of time, if there is any evidence of AKI or renal dysfunction, definitely we have better alternatives available, a CNS sparing regimen which can be introduced as a part of post-transplant immunosuppression to salvage the kidneys. So I think it's a balancing act. Again, consider the drug to drug interactions, and treat as per the tailored specific therapies what is required. Empirically, initially we can start till we get the culture sensitivity report.
So what about the NTM in soft tissues? If it is a chest wall soft infection, sometimes it's like sternal osteomyelitis or something like this.
Sure. So basically, any bone involvement, whether it is sternal osteomyelitis, usually most of the lung transplant patients or all of them, what we do is a clamshell incision where we cut across the chest, and definitely the sternal bone is also cut across, and then it is plated. So for the stabilization. So sometimes you can have wound infections, surgical site infections, and you can have a bone involvement also, which is evident on the CT scan. So definitely that requires a surgical debridement to be done along with the good antimicrobial cover, which we usually give it. Okay, sometimes we have seen patients with Mycobacterium abscesses where sometimes you may have to go for multiple surgical debridements, okay, for it to come negative or for the wounds to heal. So definitely Mycobacterium abscesses is a challenge predominantly among all the other NTMs also. Mycobacterium abscesses is a challenge. So surgical debridement, keep a low threshold. Now, whether it is in terms of doing a lobectomy, if the lung parenchyma is involved, or whether if it's a chest wall infection, then definitely whether it's a rib resection or whether removing of the plates. That is the commonest thing what we do when there is a sternal wound infection.
Yes, sir, exactly. So going ahead, Dr. Pankti, as a transplant pulmonologist, we are very worried about aspergillus or any fungal infections in the post-transplant, may it be early or a later part. So how would you treat your patients, or how would you give prophylaxis for your patients in the post-transplant period for fungus?
So we prefer voriconazole. Voriconazole is the preferred drug for aspergillus coverage, and we started immediately post-op. In patients who probably have QT prolongation, or if there is already some kind of hepatotoxicity, then probably isavuconazole can be considered in these patients. But in all cases, most of the cases, we are preferring voriconazole. Also, we do prefer nebulized amphotericin. Also, we give amphotericin nebulized, which is often used in a lot of other centers also, because these patients who have anastomosis, and in order to protect the anastomosis, which is probably ischemic and prone to more fungal infections for the first 4 to 6 weeks. So nebulized amphotericin B has been proven to protect from fungal infections. So yes, a combination of voriconazole and nebulized amphotericin B is what we prefer. And of course, because we're using
duration of prophylaxis
has to be. So duration of prophylaxis, we are initially giving for 3 to 6 months, depending how much the patient tolerates.
Okay. In our practice, what we do is we usually continue it for a year or more also sometimes.
Okay. So because in Indian setup, I feel around 6 months.
Yeah.
In Indian setup, yes. Yeah.
By going by guidelines, it would be like 6 months, but in Indian setup, especially for lung transplants, I think it is better to continue for a few more months. Sure. And one more thing, we had at KIMS Hyderabad, they have started doing local instillation of amphotericin B, liposomal amphotericin B in the trachea. So it's once in a week they do it. So that is one of the things they have started doing it as a prophylaxis in the early post-transplant period.
And how many times do they do that?
Once in a week. Once in a week they do it.
Once in a week for how long?
So for a month, till the time patient is admitted with us, then they can stop doing it.
Sure.
And what about the therapeutic options? If it is a active infection, invasive fungal infection?
So if it is an invasive fungal infection, one is to confirm the diagnosis, of course. And if it is invasive pulmonary aspergillosis, then again treatment with voriconazole with 6 milligram per kg BD and then 4 milligram per kg BD, depending on the guide. Like we follow the usual guidelines, of course, with the voriconazole. And measuring the trough levels is very important again. Measuring the 72-hour trough levels and the 6-day trough levels is very important. And depending on the trough levels, then the dose adjustment is being done. Voriconazole sensitivity is being checked. And in cases of resistance, then a combination of probably then amphotericin B and posaconazole for salvage therapies then.
Yes, agree.
Yes.
So going ahead, Pavan sir, so sometimes a patient a few months after the transplantation presents with a fever and septic shock, like a full-blown sepsis. How would you like to manage such patients in post-transplant period?
So sepsis, basically we need to identify the source of infection, and depends upon whether it's a urinary tract infection or whether it's a respiratory tract infection, etc. And wherever possible, as Dr. Unmil was telling, if it is a local source of infection is there, we need to address that. For example, if there is a urinary catheter is a source of infection, or if there is any plastic in the body which is a source of infection, you need to change that, remove that, and drain if there are any abscesses. That is the most important thing. Second will be, so post-transplant, don't be late or don't be slow in starting the antibacterial coverage. So start the empirical antibiotics, send for the cultures, try to identify the organism as early as possible, try to identify the resistance patterns as early as possible, because these patients have been in and out of hospital multiple times. There's always a risk of healthcare associated infections with caused by MDR bugs. So you have to keep a low threshold in starting antibacterials. So once the cultures are back, once you know exactly what the organism is, you can always de-escalate. And apart from that, as we discussed earlier, the immunosuppression part of it is very, very important here. So if the patient is on heavy amount of immunosuppression, we need to reduce it, for example, mycophenolate, the antimetabolites, and then continue the steroids, continue the tacrolimus. And if the sepsis is really bad, then you may have to admit them, hydrate them well, protect the other organs as much as possible, support them as much as possible. And then also there will always be a little bit of risk of rejection once you taper and stop the immunosuppression for a certain duration of time. So you have to be mindful of that also. That is why source reduction as early as possible, antibacterial institution as early as possible, and identifying the organism as early as possible are very, very important. And how to play with the antimicrobials and the immunosuppressive medications, that's an art you learn over a period of time. So that has to be considered. And also you have to repeatedly do tacrolimus level, everolimus levels, etc. more frequently to make sure that the levels are maintained adequately.
Yes, sir. And if the patient also has a respiratory failure requiring ventilation, or if they are not even maintaining on ventilatory support, because many times we see these patients, as you mentioned, they also go into acute rejections because of full-blown sepsis. So, what will you consider ECMO in such patients post-transplant?
Post-transplant, yes. So now you should understand ECMO is a bridge, right? So ECMO is a bridge to recovery or a bridge to transplant. In this group of patients, if the patient's overall condition is good, and if you think it is a salvageable condition, it's an infection which you can manage and treat, and the patient can be brought out in few days' time. We're just buying time here, basically. So why not bridge them? By that time, identify the organism, treat it, and then once the lungs recover, you can very well take them off the ECMO. So there is no contraindication here. It all depends upon the overall condition and what is your risk profile and what are you expecting in the particular group of patients. If the patient is otherwise healthy or others are well reserved, it's a bacterial infection localized to a particular lobe and patient has become hypoxic, and you can treat a particular infection with good amount of antibiotics for a period of 7 to 10 days. So bridge them to ECMO, treat the infections and take them off.
Yes, but if at all we are not able to wean them off, then in that case, would you consider redo transplant?
The redo transplant for infection per se is a challenge because you're not able to take them off the ECMO. That means the patient has gone into sepsis, septic shock, multi-organ dysfunction. In that situation, doing a redo transplant maybe obviously it's not a feasible option there. But if they end up on on ECMO, you treated the infections appropriately, as Dr. Unmil was telling. So what we do is we repeat cultures 5 days apart and make sure 2 consecutive cultures are absolutely negative. And then once the infection and the source of infection has been taken care of appropriately, but you're not able to wean the patient off the ECMO because it's either a rejection or an ARDS and the lungs have been damaged significantly, not because of infection, but because of something else. That is when it's a case-by-case discussion, of course. There are no clear-cut yes or no answers here. So if you think the patient otherwise is quite well preserved and you can give a meaningful life for next at least 2 to 3 years, then yeah, why not?
Thank you, sir. So going ahead, Unmil sir, like CMV, we also get EBV in our post-transplant patients, and they sometimes they can also lead to post-transplant lymphoproliferative disorders. So would you monitor all these patients, all the post-transplant patients for EBV?
Okay, so basically, so PTLD, if we see the incidence post lung transplant, it is usually very common, more post 6 months and obviously more than 1 year. One of the reason for getting an EBV viremia is probably an overt immunosuppression. So it is what protocol we have now made is like we have started screening for EBV viral load along with the CMV together for whenever the patient is planned for a surveillance lung biopsy and as and when required as the clinical case permits. Just a merely EBV viremia is not going to give us any clinical thought process as to what does it mean, because it's just a viremia. Probably it's an overt immunosuppression. It just would give you a green signal or maybe a red flag sign that probably you need to just optimize your immunosuppression. But I mean, if there is a viremia EBV and suppose you continuously monitor that and suppose it is increasing, or if you find any signs or symptoms of a post-transplant lymphoproliferative disorder, which is one of the commonest manifestations of which is related to EBV post-transplant. Now, the main difference between the solid organ transplant PTLD and the bone marrow post-transplant PTLD is that the bone marrow PTLD is more of a donor origin PTLD which is much more indolent as compared to the post solid organ transplant PTLD, which is more of a host origin, which is like more of a transplant recipient origin, which tend to be much more progressive. So basically, if you have a PTLD kind of a picture, definitely we need to keep a low threshold and look for the EBV viremia. If you have a EBV viremia along with the PTLD signs and symptoms, definitely we need to treat it. One of the first line of treatment is rituximab, which is usually started with, and you can have two types of responses, either a partial responser or no responses. If it's a partial responser where you have run a imaging study after 4 cycles of rituximab and you find that there is a partial response, you again run 4 more cycles of rituximab weekly, and then we again do an imaging. If there is no good response, then definitely we go to a second line of therapy, which is chemotherapy. Now there are various regimens available, whether it is RCHOP or RCUMP and etc. So basically, just a low level, just a viremia of EBV, we need to just keep it under surveillance if we pick it up. But even though the literature says that despite sometimes continuous monitoring of EBV and probably even balancing or optimizing the immunosuppression, it may not prevent the onset of PTLD. So I think just keep a low threshold of surveillance in case if you suspect it. But yes, in our program, we routinely keep surveillance of both the CMV and EBV viruses.
Very valid, sir. So going ahead, Dr. Komal, so now patients in the post-transplant period, if they get a community-acquired infection or a sore throat, something like this, and they come to you, will you will you be worried about any drug interactions in them while starting any medications?
Yes, definitely. So basically, this immunosuppression, like tacrolimus and everything, are cytochrome P450 substrates. That means they are metabolized by this enzyme. Now, the drugs which are the inducer of this enzyme will obviously decrease the dose, decrease the level of tacrolimus, and which are the inhibitors will increase the dose of the tacrolimus, and inducers will decrease. So, the level. So that's why we have to be very careful about the drug-drug interaction. As I mentioned, rifampicin will reduce the level of tacrolimus, and drugs like azoles, like voriconazole, everything will voricanazoles and other drugs like erythromycin, clarithromycin. Now here, azithromycin is safe, but erythromycin and clarithromycin are the inhibitors. Okay, so they will be increasing the dose of tacrolimus, which will lead to the toxicity. Other drugs like ciprofloxacin again is also causing the drug-drug interaction. Then metronidazole. These are the drugs which cannot be used, or there are chances of drug-drug interactions with these medicines. So for the community-acquired infections, penicillins are safe, azithromycin is safe, even cephalosporins, piperacillin, tazobactam, carbapenems, colistin, they all are the safe medicines. Even tigecyclines can be used, doxycycline can be used. So we have to make the combination out of these drugs. But again, we have to keep in mind drug-drug interactions and also side effects. As I mentioned earlier, that there should be balance of everything.
Exactly. And we also, like, for all our listeners, I would like to mention that when you get such a patient with post-transplant comes to your OPD, you can, if his patient is having his fever spikes, if you are suspecting a viral infection, community-acquired viral infection, you can hold their mycophenol and mofetil for maybe for 4-5 days. And at the same time, you can just increase the dose of steroids from maybe, you can keep it around 20 mg Isolon. And later on, you can, once the infection subsides, you can later on again increase the dose of mycophenol and mofetil. And as you had mentioned, we should be very cautious about the whenever we are starting any medications to post-transplant patients because of the risk of interactions. So going ahead, so Unmil sir, so at many of the tertiary care centers, we are now worried about the MDR bugs, and most of these are not even sensitive to even colistin also. So what are the future directions for this? And even about we have heard about a phage therapy. So what about it, sir?
So basically phage therapy, or what we say is bacteriophage, basically just to put it in a very simple language, these are basically viruses which are administered, whether it is in form of nebulization or either an oral consumption. The basic mechanism of action is basically these viruses or these virions or viral particles will attach to those specific bacterial cell walls. They will eject the genetic material into the bacterial cell, and which will replicate inside and cause lysis of the bacteria. So basically the phages are of two types. You can have a lytic phage or you can have another phage where it is called as lysosomal phage, where it will just multiply within the bacteria, but it will not lyse the bacteria. So we predominantly, what we are talking about bacteriophage, these are all lytic phages. Now, they could be either single-stranded or double-stranded. They could be either a DNA or a RNA virus. These are the virus or the viral particles which are ubiquitous across, whether it is in soil or water or air or they are present in the environment. Now, there have been case reports in the last couple of years about treating using bacteriophages for in lung transplant, predominantly also to treat with the MDRO, infections, predominantly the Pseudomonas. The Pseudomonas is something which is quite of a resistant chap with multi-drug resistant Pseudomonas, which are difficult to treat as compared to other MDRO GNBs. So predominantly the bacteriophages therapy have been tried against MDRO Pseudomonas, where all the other options of using the antibiotics have been existed, and you have repeated cultures coming positive. So either it can be in form of nebulization or it can be in form of oral consumption. Usually it is 15 days of treatment with 15 days of break. Usually the treatment continues for 3 months. We recently published a case report of bacteriophage, and which was predominantly, this was a paper which was abstract, which was selected in the International Society of Heart Lung Transplant, and that is available on the net as well. And basically this was a patient who had persistent cultures coming positive for MDR or Pseudomonas despite treating with all the IV antibiotics, and repeated airway cultures coming positive, leading to airway stenosis also of the anastomosis predominantly. And after using the bacteriophage therapy in the form of nebulized and the oral, we were able to have negative cultures possible. So basically, this is one of the promising therapies, bacteriophage, predominantly to be used in MDRO settings, and it has to be a case-to-case basis decision. It is not like that we will use for all MDRO bugs as well. So I think it has to be a case-to-case basis decision, and definitely, but it's an exciting time for treating such difficult MDRO bugs which are difficult to eliminate, predominantly in the post lung transplant settings.
Exactly, sir. Thank you for the interesting points. Now, Dr. Pankti, we are toward the end of the session now. So in lung transplant, we are worried about chronic rejections because that is the usual limiting factor in the survival. So how do you link rejections per se with the infections?
So any kind of infections, any infection, any repeated infection will lead to injury of the graft airway epithelium, right? So once this epithelium is injured, then that exposes the donor antigens, the collagen and the tubulin, and it will upregulate the MHC antigens of the donor. So this will in turn stimulate the recipient's immune system. And once the recipient's immune system is stimulated, then there is production of the donor-specific antibodies. And because of these donor-specific antibodies, so any kind of subclinical infection and chronic inflammation and repeated infections will eventually lead to fibroproliferations, which will eventually manifest CLAD. So the goal is just not to look for CLAD and whether it is developing, or it is to prevent infections. This is how infection is going to eventually lead to CLAD.
Exactly. So moving ahead, Dr. Komal, it's a cliche to say that prevention is always better than cure. So can you elaborate about the role of vaccinations in the pre-transplant period, especially if the patients are immunocompromised or if they are being considered for a transplantation?
Yes. So there are some rules that we apply for pre-transplant vaccination. First, we need to give vaccination 4 weeks prior to the transplant, especially the live vaccines. And most important vaccines are influenza vaccine, pneumococcal. If we are giving 13, then followed by 23. It can be given in 8 weeks now because we don't have the time of 1 year. COVID, if booster is required, or basic plus booster, whatever is required. Then we have to give hepatitis B. We can check the titers. Accordingly, we can give boosters wherever required. Then MMR, varicella, Shiga vaccine. So every institute have their own guideline, own benchmark according to which they are giving the vaccine. Now, for post-transplant patients, usually the live vaccines are avoided. We should not be giving live vaccines. If the vaccines are incomplete, vaccination is incomplete pre-transplant, then post-transplant we can continue it, not live vaccines, but other vaccines after 3 to 6 months of the transplant, once there is stabilization. And usually influenza vaccine should, every year we should continue giving the doses. So basically influenza, COVID, pneumococcal, MMR, varicella, hepatitis, Shiga, meningococcal, all these vaccines are given pre-transplant.
The point's very well taken. I would like to reiterate point about shingles, because many of our patients, even those who are on MMF for interstitial lung disease, many of them we see developing shingles or zoster. So all these adults should be vaccinated for shingles vaccination, even if they are not considered for transplantation, I would say.
Yes.
So towards the end, Pavan sir, apart from the pharmacological therapies and everything, what all non-pharmacological interventions would you advise your patients? Because some of our patients, like one of my patients who had undergone a transplant at in Dubai, and she had told me that I can go move around, I can go everywhere. So why are you restricting me when you are when she's back to India? So what would be your advice for such patients?
Yeah, so preventive measures, I think the vaccination part of it we have discussed a lot. So not only for the patients, we even recommend vaccines, especially the flu and the pneumococcal vaccines for the family members also, because the caretaker vaccination is also very important, because that's how the infection comes from outside world with the patient. So post-transplant, we do recommend them to take plenty of precautions. Hand hygiene, very important, and wearing a mask at least for a period of a year or so, and also avoiding dusty environment, polluted places, and construction sites, etc. Apart from that, I think the dietary precautions will be there in place as well, as it has also been discussed. So apart from that, the hygiene inside the house itself also very, very important. And once the patient is free from the hospital, when they go home, there is a lifestyle modification which happens, which will be extensively taught to the patient and the family members as to where to go, how to go, and the exercises that needs to be done in the open air, inside the house, etc. So these precautions are very, very important, especially in a country like India, where the population density is pretty high, and also if you're in a closed space, somebody is coughing and sneezing, the risk of contacting the infection, respiratory infections are very much there. So not only the contact isolation measures, even the droplet precautions, as well as the respiratory isolation precautions also has to be considered in the lung transplant case, because every time they breathe in, inadvertently they can inhale the pathogens in the surrounding, and it can cause respiratory infections in this group of patients. Apart from that, a healthy lifestyle, eating healthy food, maintaining good healthy health status is also very important, because if they're healthy and their immune status is better, then obviously their ability to fight off ward off the infections will also be much better. Nutritional status and overall health rehabilitation, all of this will contribute in the non-pharmacological methods in which patient can lead a healthy lifestyle post-transplant.
So about the young transplant patients who wants to join their professional duties, what would you advise them? Can they join their offices and everything, or what should be they be refrained from?
Yeah, very important question, especially in a place like Bangalore, because a lot of IT professionals here. So fortunately, post-COVID, the culture of work from home has been accepted widely. So we do recommend as much as possible, wherever possible, to work from home. And some institutions now, IT companies are insisting on working from the office at least once a week. So for those group of people and patients, we recommend to take adequate precautions, especially if they are inside a closed cabins with a large number of employees being present at one particular place. And so to take precautions like wearing mask at all times. And if you see a patient or an accompanied or a friend who is having acute respiratory infections, to avoid them as much as possible. If the family member has an acute respiratory infections, to stay away from the patient. And while traveling, if they're using a common cab or a common vehicle, to take precautions again, because breathing and rebreathing the same air again leads to the risk of respiratory infections. And they should lead a happy and active lifestyle post-transplant. That is, of course, one of the endpoints of doing a transplant, but also with abundant precautions to prevent respiratory infections.
Correct, exactly. So now we will be finishing our session now. It was great to have you all, sir, everybody, all the panelists. Thank you for your precious time. I would like to once again thank Chess Council of India and the organizers for this academic feast. And I hope now, because of these web series about about the lung transplantation, we could have more number of transplant, because even with the so much of respiratory disease burden, we are hardly doing 150 to 200 transplants per year. So with these webinars, we can definitely expect more number of referrals, and we can expect more number of lung transplants even in India. And last but not the least, I would like to thank Mankind for their technical support for this webinar. Thank you, everyone.
Thank you.
Just a minute. I'll just see. There is a question. Yes. No, there are. Yeah. Chat box. So Dr. Pankaj Mahbubani has asked from Pune how to cure severe lung disease non-surgical. So he has asked for the cure for severe lung disease in a non-surgical way. Dr. Unmil sir, can you answer this question? He's just asking for any terminal lung disease, but he doesn't want to consider maybe transplant he's asking for.
So this is the question is, I think, the management of severe lung disease
yes,
without transplant, right?
Yes.
Right. Yeah, exactly. Probably. Yes.
So basically, see, I mean, it all depends upon whether the underlying lung was normal or not. Now, we have seen that during COVID, and recently also we had one case where suppose you have an ARDS with an organizing pneumonia predominantly, where the underlying lung has been normal, and suppose patient lands up in a respiratory failure with either HFNC, NIV support, gets intubated. That is, and suppose requires an ECMO as a bridge to recovery. ECMO is not always as a bridge to transplant. It is also used as ECMO as a bridge to recovery. In those cohort of patients, after maybe 4 to 6 weeks, we have seen recovery happening in the lung with a appropriately planned, tailored treatment, and we have seen the patients coming out of ECMO, getting decannulated, and then after a couple of weeks going home as well. And this we have seen during COVID ARDS, and also we see come across such cases, whether it is H1N1 or whether it is myositis organizing pneumonia, etc., etc. So basically, it all depends upon whether the underlying lung was normal or not. If you have a fibrotic ILD and patient ends up in an infective exacerbation and is in ICU on HFNC or on NIV support, then definitely, if the patient is not a candidate for a transplant, or if the patient wishes not to have a transplant, I mean, it is a patient's wish and we have to respect that. So in that case, definitely we have to go for what is called as palliative care, comfort care, and help the family. So basically, I think it all depends upon whether the underlying lung is normal or not. If you have an underlying healthy lung and which has been now into an ARDS, definitely there is always a chance for a recovery happening. Predominantly, some patients may require ECMO as a bridge to recovery, but it is worth going ahead on that path.
Exactly, sir. Exactly. Thank you. So thank you, everyone. So we'll end this session now. Thank you.
Thank you.